Our esteemed guests and colleagues, Assalamu alaikum and good afternoon. I am Dr. Muhammad Shariful Islam, presenting the case. Case title was the large vessel perforation. My patient is 50 years, male patient, hypertensive and a smoker, admitted in the NICBD with the recent MI inferior on the background of CSS class 3 angina. And echocardiography shows the patient EF is 45%, and CAG shows the single vessel disease, left side is normal. That is, mid-RC is 90 to 95% stenosis. So we planned for the PCI, and pedilation was done, and accordingly, stenting was done. Stent size was 38 at the rate of 12 atm.
Sorry, Brigadier Malik sir, please come on the dais.
And
please.
Post dilatation was done.
And Dr. Jafrin Jan, please come on the dais.
Post dilatation was done, and balloon size was 3.5 into 10 NC balloon at the 16 atm pressures. But for better perfection, we again post dilatation was done, and balloon size is gradually increased. That is, previously it is 3.5. Now we take 4 size balloon at the 10 atm pressure at the 10 millimeter 20 atm pressure. Now that disaster was happened. This is the large vessel perforation, and according to severity, it is type 3. The classification system of the perforation is by the location and by the severity. According to location, this is the large vessel perforation, distal vessel perforation, and collateral septal and collateral epicardial. And according to severity, that Ellis 1, Ellis 2, and Ellis 3. Ellis 1 perforation is crater extending outside the lumen, and type 2 is the pericardial and myocardial blast, exit hole less than 1 millimeter, and it is type 3A, the contrast that when the exit hole is greater than 1 millimeter, and type 3B, perforation in the anatomical cavity or cavitary spilling. This is the algorithmic approach of the management of the large vessel perforation. The principle of this strategy is that first, maintain the hemodynamic instability by IV fluid or vasopressor, and arrange for echocardiography. If there is a cardiac tamponade or hypotension, pericardial synthesis should be done and notify the surgeons. If the patient's symptom is improved, then monitor the patients. If not improved, then treat the cause, that is large vessel perforation, that is prolonged balloon perforation is the first strategy, and then we follow the cover stent. If distal vessel perforation, embolization and cover stent may be used. If continue extravasation, try to reverse the anticoagulant. If failed, then call for the surgery. This is the FDA approved cover stent. There is 2 types of cover stent. That is single stent design and sandwich stent designs. In our country, we usually use the Grandmaster. Back to my case. The patient was hemodynamically unstable. Heart rate is gradually decreasing, and immediately TPM was done. Fluid ionotropic support was started. Patient developed VTVF, and a DC shock was given. In cath lab, echocardiography was done, ready for pericardiocentesis, but no sign of tamponade was seen. This is the prolonged balloon inflation. It is the first step of the main large vessel perforation. But we failed. Then our strategy is now the placement of the stent. The cover stent size was 3.5 into 19. After that, first cover stent deployed. Then proximally another leaking point was identified. Then we planned for the prolonged balloon dilatation, and a second cover stent was deployed. This is the final results. The cover stent delivery system is two types, that is single guide system and double guide system. In single guide system, first needed two wires and one wires containing the balloon and other wire containing the stent. When the perforated side is occluded by the balloon and then the cover stent is deployed, when cover stent is deployed at that time, the balloon and wire should be withdrawn from that vessels. In the two guide system, that is ping pong technique, that is two guide, one guide deliver the balloon and one guide deliver the stent, and procedure is the like same. When the stent is deployed, must the withdraw of the first balloon containing wire and balloon. This is the system, ping pong technique. And this is my take home message. Main vessel perforation may be immediately life threatening. Initial management should be include simultaneous efforts to balloon tamponade the perforation and maintain the hemodynamic stability. For severe perforation, active steaming into the pericardium, immediate placement of the cover stent is the main effective treatment. For less serious perforation, balloon tamponade alone may be the sufficient, but we may be use the drag eluting stent or bare metal stent. Continuous extravasation, reverse the anticoagulation and consider the potamine. If not improved, call the surgeon. Thank you all.
Excellent demonstration. This case is accepted in the UPCR 2024.